Hello everyone, today we'll be discussing an overview on congenital heart diseases. We'll start by looking at the physiology as well as the pathophysiology of fetal circulation. In fetal circulation, the right side of the heart has higher pressures compared to the left side of the heart. This pressure difference allows the shunts to remain open. In postnatal circulation, when the baby takes its first breath, pulmonary resistance decreases and blood flow through the placenta ceases. Blood commences flowing through the lungs and the pressure on the left side becomes higher than on the right side. As a result, the shunts are going to close. Congenital heart defects arise when shunts fail to close after birth. Abnormalities in the anatomy of the heart can also alter the proper flow of blood. These defects can lead to a cyanotic or a cyanotic defect. This is a brief classification of congenital heart diseases. Note that this is not a comprehensive list. So congenital heart diseases can be divided into cyanotic and acyanotic diseases. Acyanotic consists of left to right shunts, and acyanotic diseases that arise due to outflow obstruction. So under left to right shunts, we've got a ventricular septal defect, patent ductus arteriosus, and atrial septal defect. Under outflow obstruction, we've got pulmonary stenosis, aortic stenosis, and coarctation of aorta. Under cyanotic diseases, we've got tetralogy of Fallot and transposition of the great arteries. Others include total anomalous pulmonary venous return, tricuspid atresia. Developing endocardial cushions is essential in understanding why certain cardiac defects develop. So the endocardial cushions contribute to the emergence of the atrial and ventricular septa, the mitral and tricuspid valves, the conotruncal septum, and the atrioventricular septum. So when there is an endocardial cushion defect, it can cause cardiac malformations like atrial septal defect and ventricular septal defect. ASDs arise when there is a hole in the atrial septum after birth. As you can see on the diagram there, an ASD leads to communication between the right and left atrium. So there are types of atrial septic defects. So the primum type of ASD is due to inadequate development of endocardial cushions and is seen less often than the secondum type. VSDs arise when there is a hole in the ventricular septum after birth, as you can see on the second diagram on the side. A VSD leads to communication between the right and left ventricles. Conotruncal septal defects are accountable for persistent truncus arteriosus, TGA, and TOF. In persistent truncus arteriosus, a single arterial trunk originates from both the right and left ventricles. It is not able to divide into the aorta and into the pulmonary artery distally. Because of a failure of neural crest cell migration, the conotruncal ridges are not able to form, resulting in this defect, which results in the deoxygenated blood from the right ventricle mixing with the oxygenated blood from the left ventricle, causing cyanosis. In transposition of the great arteries, the aorta and pulmonary artery switch locations. In this case, the aorta originates from the right ventricle and the pulmonary artery arises from the left ventricle. As a result of the above, two independent blood circuits do not mix due to the conotruncal septum failing to spiral during development. Deoxygenated blood returns to the right side of the heart, travels through the aorta, and goes out to the body. On the other hand, oxygenated blood returns to the left side of the heart from the lungs and then travels through the pulmonary artery to go back to the lungs. So in this case, a shunt is needed for survival due to the lack of oxygenated blood being delivered to the body. In tetralogy of Fallot, there is an anterior displacement of the conotruncal septum. This condition is characterized by 4 defects, that's why it's called tetralogy. So there will be pulmonary stenosis, a ventricular septal defect, an overriding aorta, and hypertrophy of the right ventricle, as you can see on the diagram on the side. The pulmonary stenosis forces the deoxygenated blood to travel through the ventricular septal defect from the right side to the left side, leading to right ventricular hypertrophy. Because of the deoxygenated blood crossing over into the systemic circulation, the baby presents with early cyanosis. Vascular malformation may also result in congenital defects. Coarctation of the aorta develops when there is constriction of the aortic arc distal to where the subclavian artery branches off. Preductal indicates that the constriction is before the ductus arteriosus, and postductal indicates that the constriction is after the ductus arteriosus. In preductal coarctation of the aorta, deoxygenated blood travels from the right atrium to the right ventricle and then through the pulmonary artery. Because a patent ductus arteriosus is present, the deoxygenated blood crosses over to the aorta after the point of constriction. In postductal coarctation of the aorta, deoxygenated blood travels from the right atrium to the right ventricle and then through the pulmonary artery. Because there is no patent ductus arteriosus present, the deoxygenated blood does not cross over to the left side. Clinical significance. So the clinical presentation of babies with atrial septal defect is related to the size of the hole. Patients are often asymptomatic and are only detected when hearing a murmur. However, a patient with a large atrial septal defect could present with heart failure, failure to thrive, or recurrent lung infections. The murmur associated with atrial septal defect is a fixed splitting of S2 due to A2 occurring before P2, which is due to the increase in right atrial, right ventricular volumes, which ultimately increase flow through the pulmonic valve, delaying closure. The clinical presentation of babies with ventricular septal defect also depends on the defect size. Small ventricular septal defects are often asymptomatic. Larger VSDs with significant left-to-right shunting may cause failure to thrive and congestive heart failure, because the heart cannot pump enough blood to meet the body's demands. A hollow systolic murmur was auscultated at the left lower sternal border. On physical examination of babies born with patent ductus arteriosus, patients have a continuous machine-like murmur which is loudest at S2. It is best auscultated in the left infraclavicular area and associated with congenital rubella syndrome or prematurity. In tetralogy of Fallot, a child commonly presents with death spells. These spells mean that cyanosis may develop when a child is agitated. Upon physical examination, the patient will have a blue tint to their lips and around their mouth. Their skin will be damp or warm and breathing will be rapid. A child with preductal coarctation of the aorta may present with differential cyanosis. There will only be lower extremity cyanosis because the oxygenated blood is not entering the branches of the aorta that go to the upper extremities. In postductal coarctation of the aorta, a child will not present with cyanosis because a patent ductus arteriosus is not present. A child with coarctation of the aorta may also present with high blood pressure in the upper extremities because of the high pressure before constriction and low blood pressure in the lower extremities after the point of constriction. Treatment. Prostaglandins from the placenta keep the shunts in the fetus open. During birth, the shunts usually close due to the loss of prostaglandins from placental separation and increased oxygen due to respiration. However, in the management of PDA, NSAIDs like indomethacin may be given to close the shunt because it blocks the production of prostaglandins. TGA is incompatible with life except when there is another heart defect that allows blood to mix. Prostaglandins may be given to permit the oxygenated blood and deoxygenated blood to mix by keeping the ductus arteriosus open. In tetralogy of Fallot, squatting may improve symptoms. Squatting leads to kinking of the femoral arteries that increases systemic vascular resistance. As a result, the pressure of the left heart is greater than that of the right heart, reversing the shunt. However, early surgical correction is recommended. So that's all about the congenital heart diseases. If you like the video, please like, subscribe, and comment. Thank you.